Hello, my name is Kathleen Lisson. I'm a lymphedema therapist in the United States of America, and I attended the WUIP World Congress in Buenos Aires, Argentina, and I came back with pages of notes for you. So I'm going to do several videos. I'm going to do a video on the things I learned about vein health. I'm going to do a video on the things I learned about lipedema, and then I'll do another video on the lymphedema seminars that I attended right before I came to this conference. So let's start with veins. There is going to be, we're going to talk about the three types of edema with venous disease, and then we're going to go into kind of a grab bag of little tidbits, clinical pearls that I picked up. So the first thing is the three types of edema with venous disease. So there's three different types of edema. You can have venous edema, you can have lymphedema, and you can have phlebolymphedema. So the first one is venous edema. So this is relative lymphatic failure with increased venous fluid filtration, which is overwhelming the lymphatic drainage. So this is reversible if the venous hypertension reduces. So what is happening is the veins aren't working correctly. They're pushing too much fluid into the interstitium. So a good functioning lymphatic system is seeing too much fluid. So like I tell my clients, it's like the 5 p.m. The road is good. There's just a lot of cars on the road. So everything's going slowly. You're getting overwhelmed. And just like the bumper to bumper traffic, you're seeing edema. So this venous edema is because of the veins, and it can be reversible. They have to reduce the venous hypertension. So that's where you send them to the vein surgeon, to the vein experts, and have them help the client with the venous hypertension. The second one, which we know really well, is lymphedema. So lymphedema is impaired lymphatic drainage with the normal lymph loads, and that is irreversible. And we go into all the treatments that we have for that, both conservative and surgical. But lymphedema is there's impaired lymph drainage. There's a normal lymph load. So maybe there's nothing wrong with, they have swollen legs, but maybe it's not the veins. It's actually lymphedema. So that is something that the vein surgeon has to see as a differential diagnosis. And the third one is phlebolymphedema. So this is important to see the difference between just venous edema and phlebolymphedema. So in phlebolymphedema, there's a lymphatic failure as well. There's a lymphatic failure from sustained increased venous filtration, and it exhausts and damages the lymphatic drainage capacity, and it's generally irreversible because we have a problem with the lymphatic system, and then we have a problem with the venous system. So the venous system is pushing too much fluid in, and even if you help the venous system, there's still over the period of all this traffic, just traffic never ever stopped. The road itself is getting broken. There's starts to be a lymphatic failure. And then it's important to know the difference between venous edema and phlebolymphedema, because if a client has phlebolymphedema, the edema is going to remain after the venous surgery because they still have the impaired lymphatic function. So that would be a really great reason to send them to the lymphedema therapist if they're still having edema afterwards. They need to have their lymphatic system treated as well. Okay, now I have kind of a grab bag of things I learned about veins. So for the majority of patients after the venous thromboembolism, a Brazilian study found that 59% of them are going to have anxiety and depression. This is important for us because if we see someone has had a history of a venous thromboembolism, think to yourself, would they have anxiety? Would they also have depression when they're coming in to see us? Very interesting study that I wrote down. If someone had a previous DVT, deep vein thrombosis, and they have A positive blood, this may be an issue with factor VIII, and they may see an increase in subsequent miscarriages. So when I posted this on my Facebook, I got some comments back where people said, that is so interesting. That may be explaining something. So they looked at the research and they were seeing that there's so like a higher percentage than in the population of people having the miscarriages because they had the A positive blood and they had the previous DVT. So this is for you to put in the back of your mind. This may be the answer and guide someone on research if they are seeing that this is happening to them or a loved one. Um, Limited range of motion in the ankle impairs the calf pump, and the limited range of motion of the ankle can actually help or be a factor in the deterioration, the further deterioration of venous disease. So this is again an important thing where I think it's really great that in this WUIP, the veins and the lymphology are together because this is something that we're working together for the clients. Because the surgeon can do the surgery, but if they are having the limited range of motion in the ankle, they not having the calf pump that they should, they are not going to get the best results of their surgery. And that's where sending them to the PT, to the OT, to try to get that range of motion to reinforce. If we're talking to somebody about range of motion, the importance of the calf pump, this is a factor in the deterioration of your venous disease as well. Laser ablation can cause complications, as all surgery can. It can cause skin burns, it can cause a superficial thrombosis, it can cause an infection. And it's important to know what we're seeing when we're seeing somebody after their laser ablation. So I put the picture on my Facebook, but I'd encourage you to go ahead and look at images of skin burns, superficial thrombosis, and infection after laser ablation. So you kind of can know what you're looking at, and that would be a great time to refer back to their venous surgeon if you see anything like that. There was an interesting conversation about whether chronic venous disease should be renamed chronic vascular disease. So we'll stay tuned on that and see what that conversation among the venous surgeon is going to end up with. And now we'll finish this short video by looking at the difference between an arterial ulcer and a venous ulcer. So arterial ulcers are caused by insufficient blood flow. And venous ulcers are caused by inflammation that is increasing the vein pressure. So it's an ulcer, but it's in a different part of the leg, and it's caused by different reasons. So you can't just see an ulcer on somebody, and this is great education for our clients that like not all ulcers are caused by the same thing if they're a leg ulcer. So for an arterial ulcer, the ischemia is the primary cause of the reason that ulcer is happening. It's insufficient blood flow is the primary cause. But with the venous ulcer, there is ischemia, but that's due to endothelial dysfunction. That's due to venous hypertension. That's due to valvular damage. That's due to capillary thrombosis. So we're also seeing ischemia, but it's not the primary cause. It's due to some of those other factors. So it's an important thing to understand that there's a difference between arterial and venous ulcers. So I am so glad that I had the opportunity to learn all these things. And I think it's fantastic that WUIP is putting together experts on both lymphology and phlebology to work together to get the best results for the patients and to be able to understand one another's professions so that we can support the other professional that they're seeing and kind of echo what they're saying, which will have our clients be more adherent to the treatments that they are recommended to help their health. Thank you and have a great day.